So, I'm pleased today to invite Dr. Gabriela Gilmour to come speak with us. Dr. Gilmour has started a multidisciplinary clinic for people with functional neurologic disorders. So during the panel, we're going to have her share some of her expertise about what that was like and some of the benefits to patients and some of the challenges that she's encountered. Dr. Gilmour is a clinical assistant professor in the Department of Clinical Neurosciences at the University of Calgary, and she is also the program leader for the Functional Neurological Disorders program. She completed medical school and neurology residency at the University of Calgary, followed by a fellowship in movement disorders with a focus on functional movement disorders at the University of Toronto. Today, she'll be presenting about functional neurologic disorder and hEDS, overlapping syndromes, and shared mechanisms. Come on up.
Thank you. I'm going to check, do I have the microphone? Did I do it? Is it on? Yeah, okay, great. So thank you so much for having me here today and for this invitation. I'm going to shift gears a little bit from what we've been talking about this morning, and we're going to be talking a little bit more about a different, but as you'll see, very related condition, which is called functional neurological disorder. Maybe I'll start quickly with a show of hands if people here have heard of this condition. Lots of people have. That's great. That's what I love to see. Maybe 5 or 10 years ago, I think probably it would have been different how many hands I saw. So I'm really, really glad to see that. And we'll talk a little bit about why I'm even here today. In terms of disclosures, a few things that aren't related to this talk, and maybe a disclosure is that I am a neurologist and I focus on functional neurological disorder, and I'm a very strong advocate for this condition and for more education and understanding and research around this condition. I'll admit that I'm not an expert when it comes to hypermobility, and so I'll hopefully share with you, this overlap, but I'm definitely not as knowledgeable as some of the other people who've spoken on hypermobility today. In terms of the objectives, I think the first thing that I really want to talk about is what even is FND, which is functional neurological disorder for short. You'll hear me say FND a lot during this talk. And then spend a little bit of time talking about this overlap with hypermobility and thinking about some of those mechanisms. So, what is FND? FND is a common condition. It's a genuine condition. It's real. Sometimes in the past, and unfortunately even today, there's a misunderstanding that this is all in people's heads, or it's fake, or it's being put on. This is not the case. The causes it causes different symptoms for everybody. Basically, any problem that the brain can cause for various reasons, FND can be a symptom of. And finally, this is a specific diagnosis. This is something that we can rule in using our clinical assessment. And that's important because that allows us to be confident in this diagnosis and then to be able to learn more about it. FND is very much an umbrella term, just like all of these things are that we've been talking about. And depending upon what the main kind of symptom is that somebody may be experiencing, this will perhaps end up leading to a different name of a condition like functional movement disorder if there's a lot of problems with movement, functional cognitive disorder if cognition is the major concern, functional seizures if seizures are the major concern. And really for a lot of people, it's overlapping and there's lots of different symptoms that are happening, and probably it doesn't always make sense to go into these sort of nitty-gritty details and just instead think of it as FND. This is sort of a repeat of what I've just said, but some of the main sort of symptoms and the main subtypes are functional seizures, also called dissociative seizures, functional movement disorder, persistent postural perceptual dizziness, that's a mouthful. You can also call it triple PD if you really want to sound cool. That one's more around dizziness and resulting difficulties with mobility due to the dizziness. And then functional cognitive disorder. FND is currently the name that we use because I like it because it explains what's happening. It's a problem with the function of the nervous system, and we'll talk a little bit more about that shortly. In the past, other names that are not nice and not useful have been used. So things like hysteria, we don't call that hysteria anymore, and hysteria is very misunderstood, obviously. psychogenic, pseudo, conversion disorder, or just sort of this category of medically unexplained, which also obviously is very unhelpful. And so just to be totally clear, this is not the same thing as somebody who is malingering. Malingering is when people purposefully fake symptoms for the purpose of getting, legal action or something like that. This is not that. This isn't faking symptoms for any reason. This is completely involuntary. And as I already mentioned, this is not a diagnosis of exclusion. This is something that we can rule in. We can confidently diagnose this. This is kind of a busy slide, but I'll walk you through it. The point of this slide is really just to show how common this condition is and how disabling it can be. So let's see if I can do it this way. I heard this is a touch screen. Nope. Ooh. It's okay. Top left. Ooh. Okay, I'll not play around with that. I'll just walk you through it. So in the top left, this was a study done in Scotland, and they basically looked at people who are being referred to neurology clinics, outpatient clinics. And the second most frequent reason for a referral was for functional symptoms after headache. And many people who have functional symptoms also have headache and vice versa. So this is really, really common and a really common reason why somebody may see a neurologist. The next one down, that's sort of a circular shape, that one was a more recent study, and they were looking at people who were admitted to hospital and why neurology might be consulted for those people. And the number one most common reason was for functional neurological disorder. And then if you look at the bar graph on the far right, this one is looking at patients who have FND or functional symptoms and the level of disability they experience, physical disability they experience is that dark blue. And they compared that to patients who don't have FND and have other neurological conditions. And I think what you can see is that that dark blue line is the same all the way across. So regardless of what the neurological diagnosis was, whether it was FND or not, there's a similar level of disability. So we as neurologists should care about this condition. And fortunately, there's been a shift in our understanding and our ability to help patients with this condition. So that's a little bit about what is FND, and now let's talk about how it's happening, like what's happening in the brain to cause FND or functional symptoms. And so for those of you who have heard of FND before, perhaps you've heard of this sort of computer analogy. And it's the idea that our nervous system is like a computer where it has hardware. So those are like the nerves and the connections between the nerves and the connections to muscles. So that's the hardware. And then there's the software. And this is something that we don't often think about, but our brains kind of run programs. And an example of a program that we don't need to think about is breathing. So I don't think about breathing. I presume many people here don't think about breathing. It just happens automatically. But now that we're talking about thinking about breathing, now I'm like thinking about it, and now it's not happening as automatically, and it kind of feels funny, and I'm like a bit short of breath as I'm thinking about breathing. So this is an automatic program that we normally don't think about, but then when we start thinking about it, we can kind of take over, at least temporarily. And that's true for a lot of things that we do. If anybody here has learned a musical instrument in the past, when you first started playing it, you probably didn't know how to move your fingers or how to use your breath, depending upon what the instrument was. But as you practice and learn, that becomes more automatic as a movement. So those are the programs that our brain runs, and those are what is going wrong in functional neurological disorder. These automatic programs are malfunctioning and not happening automatically anymore. And that's different from other things like multiple sclerosis or stroke or other neurological conditions where there's a physical damage happening in the nervous system. Often in FND, there's a trigger. So something happens that causes new sensory or motor information. So this might be an injury, a dislocation, a fall, an accident, something like that. And because of the context of that, there might also be a fight or flight response. And we've already heard a little bit earlier today about how fight or flight is so important. And because there's a fight or flight response, the brain involuntarily puts increased importance on the body and what's happening in that moment. So the brain is focusing a lot of attention on that injury, let's say, that just happened. And the brain starts to develop expectations, and I want to be clear, this is all involuntary. This is happening sort of at a very high level in our brains. Expectations of what has happened and injury and what will happen in the future to that limb, let's say. And that's where these functional symptoms can appear. Functional symptoms appear for everybody. We all have functional symptoms in our life. If you're, let's go back to piano maybe, if you're playing piano and I'll give a personal example. I was not a very good pianist when I was younger, and I would get really, really nervous when I had to do recitals. And so I would, practice and practice, but then I would go on stage and I would have a tremor in my hand. My hands would be shaking, and I would forget how to move my fingers, and I would not play very well, and I'd be very disappointed in myself. But then as soon as I left the stage, that tremor would go away. So that's a functional symptom, but it goes away. But what happens in FND, due to various things like the symptoms happening frequently, deconditioning, other things happening, that's what leads to the symptoms staying. And so if we think now about how we diagnose FND, this is basically just showing that we diagnose FND the way we diagnose any medical condition. We meet a person who has symptoms, we ask them about their symptoms, and they share with us about their experience with their symptoms. Importantly, we examine them, and we can see what we call positive signs. Not positive in the sense that it's a good thing, but positive in the sense that it's a present sign on their examination. We may or may not plan investigations depending upon their symptoms, and then we put all those pieces together as physicians to come up with this diagnosis. So this is a rule-in process, and this has shifted in the last 10 years for neurologists with FND. When we think about what those signs are in examination, we talk a lot about, in particular, inconsistency. So a changing pattern of symptoms, moment to moment or throughout the examination, in a way that is suggestive of functional neurological disorder. I'm going to talk really briefly about some rehabilitation for FND and why this sort of matters, and then I promise I'm going to get to hypermobility shortly. FND, the reason why I think this really matters is because symptoms can get better. And even if symptoms don't get better, quality of life and disability can also get better. And so it's really important that if this is present, it gets diagnosed. We learn about what our brain is doing and what is happening in FND. And then there are some things that have been studied and shown to be helpful for FND. So basically, retraining the brain, retraining those pathways that aren't working. And we can do that from sort of a body-focused way with motor retraining physiotherapy, occupational therapy, things like that. And we can also use different psychotherapeutic techniques to, again, retrain that brain. What's really important is we recognize that people have a lot of symptoms and often other comorbidities. And so this is where we think about the importance of interdisciplinary care and different providers working together. Not everybody needs everything when it comes to FND treatment. And so sometimes working with your primary care physician and getting a diagnosis from a neurologist is enough to be able to start doing some things on your own, working in the community with physiotherapists, for example. And that may be enough to help symptoms out. But then in other cases, we may need to use more sort of complex pathways and interdisciplinary clinics. So FND is a syndrome, and on the left here, on the right, is a picture that we put together for a paper that I wrote a few years ago during my fellowship. And we were trying to show that people with FND don't just experience the sort of neurologic symptom, that's the symptom that every neurologist cares about, but actually there are so many other symptoms at play. In my clinic, we use a questionnaire with a checklist, basically saying like, tell us really briefly in a snapshot about all the different symptoms that you're experiencing. And we find that people have upwards of 20 symptoms, and they're all related to what's happening in the nervous system. And you'll see, just as one little circle, we've got some hypermobility appearing on this picture. And chronic pain is unfortunately really, really common with FND. So FND, colleagues of mine in the UK went to chronic pain clinics and they examined people for FND, and they found that 17% of people in those clinics, so high-level tertiary care, complex chronic pain clinics, also had FND. And they found that weakness was the most common symptom, and in general, motor symptoms were very, very common. That pain often preceded the onset of FND, and so we sometimes think of it as being like a risk factor for the development of FND. And people also had other functional disorders, things like irritable bowel syndrome and non-cardiac chest pain. And so what I want us to think about now is what happens when hEDS and HSD and FND overlap and are happening to one person in one body. And there's some data that's been published to show that this is something that's actually really, really common. So that's why I'm here today. That's why Dr. Minocha invited me. Multiple studies have been done, and you can see these numbers sort of big across the slide here, but all of them are showing that it's really frequent when people have FND to also have hypermobility. And when people have hypermobility, to have at least a few signs of FND, perhaps not a full diagnostic syndrome, but some symptoms of FND. So they're associated in both directions. I've kind of alluded to some stigma that does exist around FND that we're working to change. But there's still sometimes a prevailing thought, oh, it's all related to anxiety, it's all stress, or it's all a trauma response. And so when we think about this overlap with hypermobility, we see that actually that's not related. So anxiety and depression is not what leads people with hypermobility to develop FND. And in fact, the strongest predictor of developing FND in this study was hypermobility itself, not anxiety or depression. And so we can kind of think, the way I think of hypermobility as being related to FND is as a risk factor. Let's think now a bit more about some of the biological pathways and mechanisms that might be associated. And some of these things are things that came up in our first talk today. So interoception, how our brain interprets signals from our body, has been implicated in hypermobility in the research, but is also really highly tied to FND. Our brain's interoception is abnormal in FND. It is experiencing symptoms in the body in an incorrect way. And it's not that the body is necessarily sending the right signals. The problem is how the brain is interpreting those signals. Other important things are the autonomic nervous system. I find it often comes back to the autonomic nervous system, which is by neurologists often ignored, unfortunately. But we know that dysautonomia is highly tied to both conditions. And then another way we can think about what's happening in our brain is when we think about the context of proprioception and joint instability. So our brains are predictive machines, and we don't think of our brains this way, but in any context, it's much faster for our brain to think and predict what's going to be the outcome of this situation based on previous experience. And our brain has a map of what our body looks like. And so in movement, our brain is choosing how to activate muscles based on what that joint that it's moving is like. But if somebody has hypermobility, that joint might not look in that moment the way the brain thinks it should. And so then movement is going to come out wrong, and it could be a painful movement. And the brain is not very good in FND at updating what's happening in the body, those predictions. I don't know if I explained that well, but we can talk more afterwards about it for sure. But I think that this is a huge, huge piece to both conditions. There's also, I've just kind of got like a little bonus information fact here, but there's more and more research that's starting to show differences in functional connectivity in the brain in FND, and also even some structural changes that are very sort of not obviously noticeable if you just look at someone's MRI scan, but if we take big groups of people and we compare MRIs, we can see that there are some subtle structural changes. And the amygdala is really important for both hypermobility and for FND. So why is this important for the audience here today? I think it's important because these conditions are related to one another. They're commonly occurring together. But I think it's important for us to recognize when they're both present, because it might sort of impact how we plan treatment and how we think about, our daily activities. So sometimes I think these symptoms of FND might be missed in somebody who has hypermobility. And similarly, I think in somebody who has FND, it's often missed that some of the symptoms are attributable to the hypermobility that's present. So thinking about what FND symptoms might be there, think about motor symptoms in particular. So things like weakness, giving way that's not necessarily related to a joint issue or to a dislocation, for example. Think about abnormal extra movements that we wouldn't necessarily expect with hypermobility on its own. So things like tremor, jerky movements, and then thinking about sensory symptoms or seizure-like episodes as well. So why this matters is because if you're wondering, hey, some of these symptoms I have, I don't know if this is from my Ehlers-Danlos syndrome, I don't know if this is from my hypermobility, I think this is something that you can raise with your care team. Things like weakness or paralysis that's not fitting into your joint pattern or your pain pattern. If you're having seizure episodes or blackout episodes, especially if they're not related to something like POTS or blood pressure issues. Sensory symptoms that shift and change and don't really necessarily fit with the joint pattern that you may have. And I know this is, the case in many chronic illnesses, but FND especially has symptoms that tend to spread and migrate and change over time. And so if there's fluctuations like that seem sort of unexpected, that might be something to think about from an FND perspective. And the reason why I think it's worth asking your care team about this is because there are some FND-specific therapies that could potentially be added on to what you may already be doing and may be able to help provide some improvement in disability and improvement in quality of life. So this is two conditions that may be happening in one body. And so what does the research recommend? I think we have a lot of work to do here. Because we know that FND targeted physiotherapy is really helpful, but I think what we really need to learn from each other is how do we bring in the hypermobility treatment to that physiotherapy that's present for FND. Things like joint stabilization, proprioceptive training, and pacing are really complementary both for FND and for hypermobility treatment. Really important for us to screen in both directions. I know I've learned a lot from Dr. Minocha, and I'm trying to be better about screening for hypermobility in my clinic. And similarly, thinking about screening for FND from the hypermobility side of things. And there's a lot of opportunity here for research. We're only just starting to recognize that this overlap exists in the last 5-10 years. And so thinking about how can we be better about treatment, how can we work together in a better way, where does dysautonomia play a role in all of this, and trying to be able to be better about screening and recognizing people who may be at risk of developing FND. And this is something that nobody's talked about, but I'm really excited about the possibility of how do we prevent somebody with hypermobility from developing FND in the future. So if we think about what we've talked about today, the science is catching up and care is getting better for hypermobility and for FND. The overlap is real. It's not just anxiety. Symptoms are real. They're not in your head. You're not making them up. And there's a shared biological mechanism that's involved in both conditions and probably is explaining a lot of this overlap. Recognition opens the door to better care. And so thinking about these symptoms, thinking about what might be happening, and asking the people around you, your care team, about this can perhaps open some new doors around treatment. And so I'll just end off by saying your symptoms are real, but they are complex, and that complexity is real. You're not imagining it. Research is slowly getting better. Clinicians are slowly getting better. We're all learning, though, and we all learn from each other, as we've talked about already today. And so I will just quickly acknowledge my team at South Health Campus. I work with some really, really amazing rehab specialists, as well as incredible nurse and neuropsychiatrists. And I also have a lot to thank from the people who trained me in Toronto. I've got here, feel free to take photos of this if you like, some helpful resources. So neurosymptoms.org is an incredible resource about FND, put together by a leading expert in the UK for patients. And so there's lots of information on that website. I would encourage you not to read the entire website because, number one, that would take forever. It's a huge website, but also because some of it's not going to be relevant to you. And if somebody has seizures from FND and you don't, that doesn't mean you're going to get seizures from FND. So don't read that section. Read the section that matters and is meaningful to you. Physio for FMD is a big clinical trial that was done that was looking at specialized physiotherapy for FMD. FMD being functional movement disorder. I put this website up as something that could be shared with your physiotherapist. And you could also let them know that there are consensus guidelines that have been written by physiotherapists for physiotherapists on how to help patients with FND. And so that is one way that you can help advocate for the care you're receiving and making your time spent with physiotherapy even more worthwhile. The app, My FND, big fan of that app, and it has a bit of a symptom tracker as well. So if you're thinking about tracking symptoms, that's something that you could take a look at. And then here are a few different books. Not There is available on the neurosymptoms.org website, and that's a graphic novel that was written by somebody with functional seizures. I think it's really beautiful. FND Stories shares different stories of different people with FND. And then the other two on the far right, those are things that could be shared with your care team. So I thank you so much for your attention. Looking forward to answering any questions that you might have.
Thank you so much again for coming. We're very lucky. Dr. Gilmour is an international expert on this, and she's presenting some of the latest research and doing a lot of the latest research, so we're really lucky to have her. There was a lot of engagement with your talk.
I'm glad.
So I guess you kind of mentioned this, but most people, someone wrote, most people receive this diagnosis when it's difficult to determine what's happening, and you mentioned that there are clear positive signs that can be found. So I was hoping you could just talk a bit more about that.
Yeah, that's a really good question, and I think this is something that has changed a lot in 10, 15 years, where we as neurologists have recognized symptoms and signs that tell us this is the diagnosis. It turns out that FND looks like FND. It doesn't look like other things, and so in the past, especially like 90s, let's say, people would come to a doctor and they would get every test and then everything would be negative, and then the doctor might say, oh, it's medically unexplained, or they might give one of these other unhelpful terms. Nowadays, we don't need to do that because we're better at recognizing what these signs look like on the examination. I think if you have an experience, though, where you feel like your doctor's not really sure what's going on and they're just like, oh, it must be FND, it's reasonable to ask, tell me a bit more about what led to that diagnosis. I'd like to better understand. And I think coming from a place of curiosity and wanting to understand where that diagnosis came from can lead to a really nice conversation with your physician. And it may be, oh, let me show you these positive signs that I saw in your examination, and together we can understand what this means. Or it may be, well, nothing's really making sense here, so I think it might be FND, in which case I think it's reasonable to ask for a second opinion or a bit more sort of evaluation there.
Thank you. Someone's asked, can this condition change over the lifespan? Once you have it, is it there forever?
Great question, and I think a question that research is trying to answer. I think of FND in many people as being a chronic condition in the sense that it can stay around for a long time, but it tends to kind of fluctuate in terms of how much it's impacting someone. And there may be times when it's really not a big issue there at all, but then something changes and it's much more of a problem. My hope for my patients and for people living with FND is that you're able to develop skills and tools to manage those symptoms when they crop up so that they are not impacting your daily function and what you need to do with your life.
Thank you. There's a lot of questions on the theme of stigma. So one of the questions was, I've had doctors tell me not to put my FND diagnosis on forms or tell other doctors about my diagnosis. How do you feel about that?
Yeah, it's a tough one because, the stigma is real. Like, I think there's no sugarcoating it, unfortunately. I think I hope the stigma is improving and getting better and slowly easing off. And how is that happening? I think by recognizing FND is a thing, and now we know who has FND, and we can start researching FND, and we can understand these brain mechanisms that are involved. And now we understand that this isn't all in your head and you're not making it up, but actually there are malfunctioning brain networks that are leading to symptoms that can be retrained. And so I think as we start to learn more about what's happening, we get better at identifying it. Then hopefully we get better at treating it. And as this process evolves over time, it's a much more believed condition by the medical community as a whole. There's definitely groups that are, more in the future with FND and others that are more behind. And I think that, or I hope by building clinics for people with FND and talking about FND, we're improving the recognition of it and we're reducing some of that stigma. And then something that's really important to me is education. And we always have learners in my clinic, for example. And I think I've seen a huge shift in how residents and physicians understand FND because they've had the opportunity to meet people with FND and to learn about the condition. So I think it's improving the stigma, but it is still there. To get back to the question, I think whenever you're disclosing a diagnosis, it's important to think about what am I aiming for in this? And so if you're going to see a neurologist, I think it's important to share that you have been diagnosed with FND, and then hopefully that neurologist can help you, find the right resources to help manage that condition. I think if you're, at your office, it may be helpful not to necessarily diagnose or disclose FND, but to say these are the accommodations I need, as we've talked about earlier today. So I think thinking about, what is my goal in it? I don't know if that's fully answering that question, but.
Yeah, no, that totally makes sense. There's a lot of questions around dysautonomia, postural orthostatic tachycardia syndrome, and then postural perceptual dizziness. Mm-hmm. So I guess, what's your approach to that? And I know there's still a lot of research going on. How are they all related? Can people have both?
Yeah, that's a big question, and I don't think I have an answer, like an easy, quick answer. Yes, they're related. That's my easy, quick answer. My approach is individualized, and I think what I try to do, and I hope I can sometimes achieve in my clinic, is meeting people where they're at and understanding, okay, what are your symptoms? What's bothering you? And then trying to understand, is this being driven by dysautonomia, in which case maybe that should be the primary kind of focus, at least for now, of treatment. Is this being driven by hypermobility, in which case maybe that needs to be the focus? Is it FND, in which case that's supposed to, is it all of the above? That's when it gets harder and things become a bit more fragmented. But yes, I don't know. In terms of triple PD, so that's a condition that can present similarly to POTS for sure. Often what people experience is a dizziness, a feeling of movement, like being on a boat, sometimes some spinning sensation, and that tends to be worse when upright in visually stimulating environments, so bright lights, lots of colors, motion in the environment. The classic worst place ever would be the grocery store, because you've got it's cold and it's or too hot, and you've got all these different colors of the cereal boxes, and you're trying to walk down the aisle, so things are moving past you, and the lights are awful. So that's a terrible place for somebody with triple PD. That dizziness, though, is a little bit different than the lightheadedness that would be more typical in POTS.
Thanks. Some people are wondering just if you could talk a bit more about the relationships between pain and FND. You mentioned it briefly, and specifically things like concussion or chronic regional pain syndrome. How do those things kind of relate?
Yeah, so I this will be my like on my soapbox here. I think the medical field, especially when it comes to FND and these things, is behind because of the siloed fields that we work in. So I work in neurology, and you work as a physiatrist, which is doing a little bit more than neurologists are. You've got cardiologists. So we've got all these different sort of siloed specialties, and we don't have enough crosstalk between them. So for a long time, complex regional pain syndrome, for example, was sort of noted to be related to dystonia being abnormal muscle contractions. Now we're starting to recognize that actually, this dystonia is probably a functional dystonia that's happening related to FND and complex regional pain syndrome. So that's one sort of major overlap in that it's probably one thing altogether. Concussion is another really, really important trigger for FND. And so somebody may have a concussion or a mild head injury and develop post-concussive symptoms, and those may persist, and then functional FND symptoms come and exist as well, and we see a lot of overlap here. In Calgary, I'm doing some work with Dr. Diebert, who's a concussion expert, also a physiatrist, and we're definitely seeing that there's a clear group of people who develop FND after concussion. So all of these conditions are overlapping, and we need to work more together, I think, as medical professionals to learn from each other.
Thanks. A lot of people are curious about any interactions between hEDS and ADHD and ADHD and FND. So can you talk about maybe any overlap there?
Yeah.
And a few people have asked about the amygdala and ADHD and FND.
Exactly. I can definitely talk about ADHD and neurodiversity in general in the context of FND. I would say I am less knowledgeable when it comes to the hEDS side of things, but again, short answer is yes. So neurodiversity, ADHD, autism spectrum disorder are much more prevalent in patients or in people who have FND. I think of them as a risk factor as well. So just like I was talking about, hypermobility is a risk factor. I think of these as being risk factors. The brains, our brains, as we talked about, being predictive organs, needing to note interoception, all of this is the changes, or not changes, but the things that are different when somebody has ADHD or autism spectrum disorder, that's going to be related to how FND can develop. So long story short, yes. We also see as well that people who have a first-degree family member, so sibling, parent, child with autism spectrum disorder, also have higher likelihood of FND. So even not having a diagnosed condition yourself, but somebody in the family may be a risk factor.
That's interesting. Some people are wondering about childhood trauma and FND, if it's kind of more prevalent, and how childhood trauma might rewire the brain to predispose you to FND.
Yeah, so trauma and FND has a long history, and in the past, there was this view that every person who develops FND had a trauma in their life, and that's where this term conversion disorder comes from. So it's the idea that trauma gets converted into neurological symptoms in the body. We no longer think of it as being so black and white. We know that trauma is, unfortunately, and traumatic experiences are very prevalent in the community in general, and not everybody develops FND. And similarly, we know that many people who develop FND don't have trauma. But there is a higher incidence of childhood trauma and in particular childhood neglect in FND in large groups. So what that means for one individual, we don't know, but if we look at a big group of people, we see that that's a bit more prevalent. Now, how does that relate to the mechanism? Well, we've talked a little bit about the autonomic nervous system already, and we know that childhood trauma impacts our nervous system at important time of development. And living in fight or flight mode happens when we experience trauma, especially in childhood, and it can be very hard to get out of fight or flight mode. Fight or flight mode is when the nervous system is less likely to work well, and that's when FND happens. So, it's a pretty logical progression. But I think I would just emphasize that FND is, yes, one condition we're talking about, but it's different for everybody. And so how symptoms appear and why symptoms appear for one person may be different than for somebody else.
Thank you. A few people are wondering just about terminology. So one of the questions was, is the term functional dissociative seizures replacing previous terms like psychogenic non-epileptic seizures?
Yeah. Yes, it is. So this has been the slowest one for us to change as a medical community. This psychogenic non-epileptic seizures was a very sort of sticky name for a very long time. Sticky in the sense that everybody was using it, and I think it doesn't fully explain what's happening. In functional seizures, dissociation, which is a brain mechanism, is a sort of prevalent mechanism that's happening, and so that's where that shift is coming. Dissociation and dissociative seizures, that's a term that's used a lot in the UK. I would say like a little less than in Canada. It was not something that I learned about when I was going through my medical training. And so that's where they've kind of combined the name functional dissociative seizures to kind of capture all of that. And yes, officially the International League Against Epilepsy, which is the large sort of epilepsy medical body, has put out a memo saying that we're going to call it functional dissociative seizures now.
Thank you. We have a lot of clinicians in the crowd as well, so we were just hoping you could explain a bit more in detail, what does physiotherapy for FND look like, and how does it differ from, say, physiotherapy for HSD, hEDS, and any resources? You mentioned a website, but how do people access that kind of targeted physio?
Yeah, so I would say that FND-focused physiotherapy, which we also call motor retraining physiotherapy, is kind of the opposite of standard physiotherapy. So if you break your arm, for example, and you go to a physiotherapist, they're going to do strengthening with you, flexibility with you, a lot of like focusing on the arm that was broken and retraining that arm. Whereas what FND rehabilitation and physiotherapy is trying to do is retrain the brain, not the arm. And so it's going to be more about activities, so not just like weightlifting or stretching. It's going to be about whole body movements and integrating different things like distraction. So getting the brain doing other things than using the arm, and then noticing how that's helping the arm's movement, for example. It's going to be about using mirrors to look at your body without feeling your body in a different way. It's going to be about practicing doing dual tasks and movements in different ways to try and make the body move in a more normal way. So it's quite different and quite specialized. So how do we access that? It's always the challenge is access. I can say, at least in Calgary, we're very lucky because we have a handful of physiotherapists in the community who know a lot about FND and have done lots of training and worked with many people with FND. So definitely some good resources here. There's also some really good resources online. So there's on YouTube, one of the UK NHS trusts. If you Google NHS FND treatment, there's some videos on how to kind of do sit to stand and different types of basic movements with an FND focused lens. And then we also have, as I mentioned, some of those consensus guidelines and things that could be shared with your physiotherapists.
Perfect. Thanks. And what we can do is in the resources that we'll send out after, where we can get the names of the Calgary physiotherapists.
Definitely.
Okay. Well, thank you so much, Dr. Gilmour. We really appreciate it.
Thanks, everyone.